Welcome to this explainer. Okay, I want you to picture this. A patient is sitting in your clinic, and they are just absolutely exhausted and in pure agony. They've been suffering for 6 long months. They tell you they were diagnosed with bleeding hemorrhoids by a previous clinician, and they were handed some hydrocortisone creams to treat it. But guess what? The creams didn't help at all. In fact, the pain just got worse. It's a visceral, incredibly painful puzzle, and unfortunately, it's a tragic presentation we see way too often in clinical practice.
So we have to ask the critical question, the one that trips up almost every junior trainee out there. Why is this tear failing to heal? It's the ultimate diagnostic trap, right? Because the failure to heal here, it isn't about a lack of epithelial growth factors. It's definitely not just a simple wound care issue. It is actually a hidden microvascular trap created by the patient's very own body.
If you really want to understand the urgency here, you just have to listen to the patients. They literally describe the experience of defecation as feeling like passing shards of broken glass. And the nightmare doesn't just end when they leave the bathroom. For up to 6 hours afterward, their pelvis throbs with this sickening, unrelenting ache. Correctly diagnosing this condition isn't just some academic exercise. It matters immensely, because this level of daily, excruciating pain completely shatters a person's quality of life.
All right, let's take a quick look at the syllabus for today. First, we're going to cover the clinical misdiagnosis trap. Then, the sphincter ischemia cycle. 3, diagnosing the proctology triad. 4, medical sphincterotomy options. And finally, number 5, the surgical gold standard.
Let's dive right into Section 1, the clinical misdiagnosis trap.
You know, confusing this condition with hemorrhoids is probably the single most common error junior trainees make. So what is it exactly? A chronic anal fissure is a longitudinal tear in the anoderm distal to the dentate line. But the real key to that chronic label is that it persists beyond 6 to 8 weeks. And why does it persist? Because it represents a complete failure of microvascular perfusion. This isn't some rare anomaly either. These fissures actually account for up to 10% of all proctology visits globally.
Moving right along to Section 2, the sphincter ischemia cycle.
The real story here is in the numbers. When trauma occurs to the anoderm, the resulting hypertonus drives the resting anal pressure way up, between 90 and 120 millimeters of mercury. Just contrast that against a normal resting pressure of about 60 to 70. This extreme pressure is a game changer, because it actually exceeds the arteriolar perfusion pressure of the posterior penetrating branches of the inferior rectal artery.
Let's think about this visually for a second. Think of the internal anal sphincter like a tight rubber band, just completely strangling the garden hose of your blood supply. When the initial tear hurts, the muscle spasms. That spasm clamps the hose down even tighter, totally cutting off the blood flow. This localized ischemia causes more pain, which in turn drives even more spasm. You're literally stuck in a vicious cycle. Simply put, you cannot heal the lawn, the epithelial tear, until you release the tourniquet of that muscular spasm.
Next up, Section 3. Diagnosing the proctology triad. Now, a quick, absolutely vital note here. Digital rectal exams and anoscopy are heavily contraindicated on initial presentation because of the severe pain they cause. Gentle inspection by simply spreading the buttocks is all you need, and frankly, it's all the patient can tolerate.
So, during that gentle inspection, you're looking for 3 very distinct physical landmarks. First off, you'll see the exposed, pearly white transverse fibers of the internal anal sphincter sitting right there at the base of the ulcer. Second, you'll spot a sentinel pile, which is a distal hypertrophied skin tag caused by chronic edema. And third, a hypertrophied anal papilla. That's a proximal mucosal prominence. Seeing this exact triad, that confirms chronicity.
Now, I need you to listen to me very carefully here. If you were in the clinic and you see an anal fissure located laterally, like at the 3 o'clock or 9 o'clock position, stop. These off-midline fissures are absolutely not simple hypertonic fissures. They are screaming red flags that require immediate alternative workups for underlying conditions like Crohn's disease, tuberculosis, HIV, syphilis, or even anal squamous cell carcinoma. Do not just treat these as standard fissures. All right, before we shift gears and look at exactly how we cure the standard chronic fissure, I have a quick favor to ask. Help us cure the algorithm. If you're finding this clinical masterclass helpful, please share this explainer, hit subscribe, and give us a thumbs up. It genuinely helps us keep bringing you these deep dives. Getting back to it, this diagnostic framework really summarizes how the disease evolves. Notice how the mechanical shear stress of an acute, fresh tear, one lasting under 6 weeks, morphs once you cross that 8-week mark. It turns into a deep, fibrotic ulcer driven by microvascular ischemia and reflex muscle spasm. It transforms from a simple mechanical problem into a highly complex ischemic nightmare.
Let's move right into Section 4, Medical Sphincterotomy Options.
The primary goal here is straightforward, but it's super delicate. We must lower the resting pressure of the sphincter without irreversibly cutting the muscle. So, looking at our first-line medical options, we're mostly comparing topical nitrates, like 0.2% GTN, against topical calcium channel blockers, or CCBs, like diltiazem. Both of these offer a solid 65 to 70% healing efficacy, but here's the catch. GTN comes with a massive 30% non-compliance rate because it causes severe, throbbing headaches. CCBs, on the other hand, deliver that exact same healing rate, but with a highly favorable, much more tolerable side effect profile.
Now, what if topical ointments just fail entirely? That's where botulinum toxin comes in as an incredibly powerful bridge therapy. By injecting 20 to 50 units directly into the internal anal sphincter, you essentially block the release of acetylcholine. This induces a temporary chemical sphincterotomy, lasting for about 2 to 3 months. It gives that ischemic tissue the precious time and blood flow it desperately needs to heal, long before you ever have to consider permanent surgical intervention.
And that brings us to our final section, Section 5, the surgical gold standard.
When things are totally refractory, we look to the 2012 Nelson-Cochrane Review, which notes that LIS, lateral internal sphincterotomy, boasts a phenomenal cure rate of over 95%. But pay attention to the subtle yet really critical differences in international guidelines here. The American Society, the ASCRS, lists surgical LIS as the direct procedure of choice for chronic refractory fissures. The European Society, the ESCP, however, specifically pushes Botox first for high-risk patients before ever moving to LIS.
And speaking of high risk, we have a major alert here. If you have a patient with baseline weak sphincters, say multiparous females who've given birth multiple times, elderly patients, or anyone with prior perineal tears, performing an LIS without first getting an endoanal ultrasound risks causing severe, permanent incontinence. In these vulnerable populations, utilizing dermal flaps or relying on Botox is by far the safer route. You absolutely cannot just cut muscle blindly.
I want to wrap up our clinical instruction today with this crucial piece of bedside wisdom. Never, ever perform LIJS in the posterior midline where the fissure is actually located. If you cut in that specific, wrong anatomical location, healing is severely delayed and you risk leaving the patient with a keyhole deformity. The devastating consequence of that is permanent fecal seepage. It's a surgical error you just cannot easily undo. So I'll leave you with this final thought for the clinic. Knowing what we know now, that a chronic fissure isn't just a stubborn tear, but a physiological ischemic trap, how will you shift your diagnostic approach tomorrow to protect your patient's long-term quality of life? Because correctly identifying this condition, recognizing those red flags, and meticulously escalating from topicals to surgery is the absolute key to doing no harm. Thanks so much for joining me for this explainer, and I'll see you in the next one.